Gentlemen, I was asked to give you some insight about these guidelines. As Hans was saying, these were really a joint effort from the European Society of Cardiology and the European Association for the Study of Diabetes. So really a multidisciplinary task. We have patients with coronary disease and we have patients with diabetes, and frequently we have patients with both of these conditions. So obviously there is always a main diagnosis. So and this is when we see the patient, we cardiologists, we see the patient on the right side of the screen. So the main diagnosis is for us cardiovascular disease, and then we want to check whether or not the patient has diabetes, and diabetes may be known or the diabetes may be unknown. Obviously, the diabetologist will see it in another way. He gets the patient with diabetes, and then his task, or the task of the internist, to go and see whether the patient has associated cardiovascular disease. And so, if the patient has the diabetes is unknown, then these guidelines tell us we should actively look for diabetes. And this is obvious because it's a major cardiovascular condition. So the diagnosis of diabetes has been somehow changed over the years. There was some definition, WHO until 2011, where actually the hemoglobin A1C was not so strongly recommended, but already in the recommendation 2013 of the American Diabetes Association and now also the European Society of Cardiology. So the hemoglobin A1C really is one of the mainstay of the diagnosis of diabetes. So if you have a hemoglobin A1C greater than 6.5% and you have a fasting plasma glucose of greater than 7 millimole per liter, then you have the diagnosis of diabetes. We know that there are some gray zone, such as isolated impaired fasting glucose or isolated pathologic glucose tolerance test. We know that those patients have a certain proportion of risk of getting diabetes, but this is not really the main topic of today. So with respect to the recommendation for diagnosis of diabetes, the European Society of Cardiology recommend, as I said, the hemoglobin A1C and fasting plasma glucose to make the diagnosis. And the OGTT, so oral glucose tolerance test, is limited for patients where the diagnosis is still in doubt. So the level of recommendation for hemoglobin A1C and fasting plasma glucose is quite strong with class 1 indication. And this is true also for screening. So hemoglobin A1C and fasting plasma glucose are a useful tool for screening for diabetes. So we have heard about the risk score and the risk stratification, and I give you one more additional risk stratification specifically for diabetic patient. And so the guidelines state that the usual risk stratification tool and this risk engine that we all know about are difficult to apply for diabetic patients. For diabetic patients, the guidelines recommend just two simple diagnoses, being high risk in terms of cardiovascular risk or very high risk. So very high risk meaning you have diabetes and you have an additional, at least one additional risk factor, or you have target organ damage, then you are automatically at very high risk. And if you have just diabetes, then, which is rare, then you are at high risk. So there is no such thing as a low-risk diabetic patient according to this risk stratification. Obviously, in addition to the associated cardiovascular risk factor, you have additional parameters that may allow to consolidate the risk of the patient, such as the ankle brachial index, carotid intima medial thickness, arterial stiffness. These are all incremental predictors of risk for the diabetic patients, but at least intima medial thickness and arterial stiffness are not routinely recommended. So with respect to the classification, as I told you, very high risk is considered any diabetic patient with an additional cardiovascular risk factor or organ damage. One issue we have heard about the screening of myocardial ischemia in the stable guidelines for stable coronary disease. The recommendation for looking for ischemia in diabetic patients in these guidelines are more conservative than in the past. And actually, for patients that are asymptomatic, screening for silent ischemia, myocardial ischemia, may be considered only in selected high-risk patients with diabetes. So the role of active search for silent ischemia has been dramatically reduced over the time in diabetic patients. Obviously, we have lifestyle changes, and I don't make the list of you have to quit smoking and all these things. These are obviously valuable for diabetic patients in particular, and is a very strong class of recommendation. But more important is to which extent should we target the glycemic control of the patient. It's been really a matter of debate over the years according to recent trials. And I think we have to divide microvascular disease prevention and macrovascular disease prevention. So for microvascular disease prevention, a level below hemoglobin A1c of 7 has been consistently demonstrated to be beneficial to prevent microvascular complication of diabetes. The issue is more controversial for macrovascular macrovascular complication. And although the macrovascular complication have been associated with the degree of hyperglycemia, it is unclear and may be dependent on the patient categories to which level of hemoglobin A1c you have to lower in order to prevent macrovascular complication. So overall, the evidence for target hemoglobin A1c for prevention of macrovascular complication is less evident. So the target, according to this, the target for the ideal hemoglobin A1c have been somehow smoothened. Although ideally you should target for hemoglobin A1c less than 7%, because in addition you have a benefit of microvascular complication. Then for macrovascular complication, the things get a little bit differentiated. So if you have a young patient with long life expectancy, short duration of diabetes, then you should really aim for a very tight glucose control, hemoglobin A1c in the range of 6 and 6.5%. If you have an elderly patient, then you should be more, let's say, generous with him. And maybe if you have a very old patient, long-standing diabetes, already complication of the disease, then you should be more generous with him, and you may want to target hemoglobin A1c in the range of 7.5 to 8%. What we want to do and what we have understood over the years, we want to absolutely prevent hypoglycemia, because hypoglycemia may be even more detrimental than having an optimal blood glucose control. So we have to shift away from one target for all to a more individualized target of blood glucose control. And so we have understood that hypoglycemia may be a deadly condition, especially in patients with coronary artery disease. And this may be one of the reasons that having a too tight control of glucose level maybe have been detrimental in some of the randomized trials. So what do the recommendations tell us in summary about blood glucose control in patients with diabetes? So is obviously you need to control the glucose level, but this needs to be targeted according to the disease of the patient, to the age of the patient, and so you should not apply all the target for the same target for all the patients. So this, I think, is not from the guidelines of the EASD, but it's very nice slide that make us understand how we should treat the diabetic patient, how should we aim for the blood glucose target. So we have more stringent blood glucose control, and we have a less stringent one. And we have a multitude of parameters that we have to look. So the more motivated is, the less the shorten of the duration of diabetes is, the longer the life expectancy, the absent the comorbidities, and so on, more absent the vascular complication, then we should be very aggressive with this patient. We should really aim for the optimal blood glucose control. The less motivated the patient, the older, the more comorbid, the shorter life expectancy, the more softer we should be in targeting blood glucose control. We have heard about blood pressure control. Somehow, in the diabetic patient, we are now a little bit more generous than in the general population. And once again, the lower may not be the better for diabetic patient. This is true for blood pressure, and it's true also for blood glucose. So what are the recommendations in respect to blood pressure control in diabetic patients? So the target for diabetic patient is class 1 indication is 140 over 85 millimeters of mercury. What about statin therapy? Statin therapy in secondary prevention of patient, it depends on the risk of the diabetic patient. So if the patient is at a very high risk, then the target is a stringent one, less than 1.8 millimole per liter. And obviously, many of our diabetic patients are at very high risk, according to what I told you before. But if the patient is at high risk, so not very high risk, then you may aim for a target LDL less than 2.5 millimole per liter. Aspirin, also an issue with diabetic. So we used to be very aggressive in prescribing aspirin, even asymptomatic diabetic patients. But now aspirin remains recommended just for patients who are for secondary prevention and or in very limited number of cases with primary prevention. So with respect to secondary prevention, to primary prevention, now the class for aspirin is really 2B. So maybe consider for patients at high risk on an individual basis. So it's over the time when we gave aspirin to all our asymptomatic diabetic patients. Lifestyle modification, we know all of this, and this is a list of all the optimal target that you should aim for, and I already mentioned them before. So with respect to revascularization, we have heard about this, and we will have newer guidelines of diabetes and revascularization. So revascularization in general, and also for diabetic patient coming at the EASD 2014. So what do these guidelines tell us? That actually optimal medical management is the preferred treatment in patients with stable coronary disease and diabetes, unless large ischemic area are present, or left main or proximal lesion. So really a more conservative approach for diabetic patients. And with respect to the type of surgery, we already heard it before also from our colleague surgeons, the complex the disease, the more the patient should benefit from surgery, and it is particularly true for diabetic patients. With respect to PCI, drug-eluting stents are clearly superior to bare metal stent, also in patients, and especially so in patients with diabetes, because they are at higher risk for restenosis. So what is new since the previous edition of the guidelines? There is a simplified diagnostic. Now we have heard that hemoglobin A1C and fasting plasma glucose are first for the diagnosis of diabetes. There is a simplified risk assessment, only very high risk or high risk. Weight stabilization, and not get into the details, but we try to aim for weight stabilization more than weight reduction, and the dietary recommendations are less restrictive than in the past. Primary prevention, no aspirin for people free of cardiovascular disease. Glycemic target, less strict and individualized according to the patient type. Blood pressure, somehow again less strict than in the past. Revascularization, if very simple coronary artery disease, go for conservative management. If complex multivessel coronary disease, then as a general rule, CABG prefer than PCI. So there are still things that we don't know. So we don't know what are the long-term cardiovascular risks for most glucose-lowering treatment. We still don't know what is the best glucose-lowering treatment, to what target to prevent cardiovascular events. We don't know what is the best antithrombotic, antiplatelet regimen for diabetic patient for long-term prevention. We don't know what is the optimal level of blood glucose for patient coming with acute coronary syndrome. How tight should we target blood glucose in the acute phase, and what type of drugs? And the role of hypoglycemia still needs to be elucidated in association with increased cardiovascular risk. And I thank you for your attention.
Thank you very much, Marco, for this nice overview, for these new guidelines. Are there questions from the audience? Remarks from the panel, please, Franco.
Marco, I appreciate very much your presentation, and I hope that you agree with me that the patients in the general practice, the diabetic, are more than 60 years old in my practice. But what would you like to do to look for micro or the macro complications, vascular complications in this collective of patients?
So definitely you need to look for a microvascular complication if the first time that you see the patient. So he will need for sure at least, as was said before, a renal function test, and also look for microalbuminuria. This is definitely the most important thing. And then, according to his risk, you have to treat him aggressively with cardiovascular prevention.
Stefan?
In diabetic patients, it's also the question of silent asymptomatic ischemia. Yeah. At what stage of diabetes do you think of silent ischemia as a potential degenerated heart? In every diabetic, or just if you had renal or aortic disease as well?
Yeah, so we don't know. So if we look, for example, patients who are coming with acute coronary syndrome, clearly the fact that they have more frequently atypical presentation is undoubtedly there. Now, likely is a most advanced stage of the disease. But let's say overall, maybe the importance of the silent ischemia has been a little bit overstated in the past, because we have hoped that looking aggressively for silent myocardial ischemia would improve the prognosis of the patient. But then there was this DIAP study that looked really into this active search for silent ischemia in diabetic patient asymptomatic, and unfortunately, the first information is that the silent ischemia was much rarer than we have thought, and the second one, that actually there was no knowing that the patient had silent ischemia did not change his prognosis. So we are really coming back from this active search of silent ischemia in all asymptomatic patients.
Other comments? Yes, please, Francesco. The view of the surgeon.
Yes. Yeah. What we have found is that a considerable amount of patients that come to surgery usually have a diabetic situation which is not stable. And sometimes we are forced to operate them, although they have values which are, of course, not good. Very high glucose and very high glycated hemoglobin. What we found out is that it is very difficult to manage this patient after the operation, especially in this issue. And we usually perform the correction with the insulin pump. But we found out that the patient do better if we do not decrease the blood sugar below 8 or 9. And we had some patient in which we had very dangerous hypoglycemia. I don't know whether you also share this view.
Yes, absolutely. I mean, I think in many fields of cardiology, we have this simplistic way saying the more the better, or the lower the better. So the more stent, the better is not true. The lower the glucose, the better is not true. The lower the blood pressure, is better is not true. So I think that indeed there was a lot of deception on the tight blood glucose control in the acute phase. The surgery, maybe intensive care, maybe acute myocardial infarction. And especially because in acute myocardial infarction, there was a first Glycaemic study showing that you should, or suggesting, randomized, that you should really aggressive lower glucose with insulin, and this would be beneficial. And then there was a second, larger study that could not replicate this. So at the end, we have come to understand that hypoglycemia is very dangerous. And maybe also the reason, as I said, for increased event rates in some of the glucose-lowering trials. So definitely, we should control the blood glucose in the ICU, post-operative setting, myocardial infarction, but definitely not as low as we were using to do it, and we don't know which one is the best agent.
Other questions or remarks? Yes, please.
Marco, I'm a little bit confused. I have a patient coming, we know that he has coronary artery disease, and then you do oral glucose tolerance test?
The patient is diabetic or not? You don't know? No.
You don't know?
No, if you don't know, then you do a fasted plasma glucose and you do hemoglobin A1C.
Yeah. But
no plasma, no oral glucose test.
What else, if it's not an overt diabetic, then your strategy is the same as if he would be, if he would have impaired glucose tolerance.
Yes, no, we are not looking for the impaired glucose tolerance. We are looking for diabetes. So you should do a fasting plasma glucose and hemoglobin A1C, not oral fasting plasma glucose, not a glucose tolerance test.
Can you tell me the typical patient which is uncertain, and in which situation would you use an oral glucose tolerance test?
Actually, we barely never use it. But we do, I was talking about fasting plasma glucose.
We will have some patients. We know that patients with coronary artery disease, they could have that, but we don't have an effective intervention tool. We know that patient population has an increased risk, but we don't know what we have to do. Maybe we have, the only thing is that we have to reduce their overall cardiovascular risk, but nothing else.
So this impaired fasting plasma glucose was also raised for acute coronary syndrome patient, because we know that there is a large proportion of patients which have at the presentation some kind of impaired glucose tolerance metabolism. But actually, we don't know what this implies, and we don't know if we have to treat this patient differently. Actually, we are looking into this in the SPOON program, and we are looking now at fast plasma glucose at 1 year, and we see that we are misclassifying patient in the acute phase. So for us, it's important to know whether the patient has diabetes, yes or no, in the acute phase. For the gray zone, we still don't know what to do with that.
And can you tell us, in short word, which is the patient with diabetes with low risk?
If you have diabetes, no low risk. According to this definition, there is high risk, very high risk. So high risk, if you have just diabetes, no target organ damage, and no additional risk factor, which is absolutely rare. So basically, most of your patients will be very high risk.
But in this, you at the end, you give us a word about patient diabetes with low risk. And that patient shouldn't get aspirin. So give us an example of a patient with diabetes and low risk, and which doesn't need aspirin. Is it type?
Yeah, but actually, the low risk is not here. So. There is the aspirin in primary prevention is only for selected, may be used for selected very high risk patients. So most of your patients in primary prevention do not need aspirin, your diabetic patient. This is the important message.
So the patient with diabetes without microalbuminuria, you should measure the.
But you don't give aspirin in primary prevention in this patient. So aspirin is reserved for secondary prevention, and very few, very high risk may be used in primary prevention. So as the bottom line, no aspirin for primary prevention in diabetic patients.
Yes, for sure, but we are in that field a little bit confused at the higher level, because if you have a diabetes type 2, then you, with that, have in the AGLA score, or you are classified, where are you classified then?
But you don't need aspirin. If it is primary prevention, there is no benefit of aspirin.
Okay. Other questions or remarks?
I have a last remarks. If you don't forget that in real life, these diabetic patients are hypertensive and have vascular damage. Please don't forget it.
These new guidelines for the surgeon, does it have an impact, a new impact, or does it have a confirmation of your way you treated your patients already before?
I think this is a confirmation that we are on the right track as far as treatment of patients is concerned. There is a good evidence that diabetes patient will, of course, be the patient who will profit the most from a coronary artery bypass, and I think that they represent a big challenge anyway. But I think that the results as far as revascularization is concerned with the surgical therapy is quite good. So I mean, it confirms what actually we have been seeing lately.
Can you confirm that too?
Yeah, I fully agree.
Okay. So I think if there are no other questions, no other remarks, thank you very much to all the presenters, to the panel, and to the audience. And I think we can take home a message that not every time the lower is the better. And I hope that you are not confused at the higher level. Thank you very much.